Alright, so this one says a nurse is assisting with the preparation of an in-service program about the stages of acute kidney injury or acute kidney failure. Which of the following pieces of information should the nurse suggest about pre-renal azotemia? So the first thing we have to do is define our terminology, right? The word azotemia is increased urea, nitrogen in blood, meaning that your kidneys are not doing their job or something's going on where you have an excessive amount of waste, of nitrogenous waste in the bloodstream. That's what azotemia means. Your kidneys normally excrete uric acid, and that's how we maintain homeostasis, right? But right now the patient has azotemia, so that's excessive waste. We good with that? All right. Then it says the patient had acute kidney injury, AKI, or acute kidney failure. You should know that when it comes to acute kidney injury or acute kidney failure, there's 3 phases. It's not like your chronic renal failure or your end-stage renal failure where like they just shut down and it's over and you need dialysis or a kidney transplant. That's not how this one manifests. You guys recall us discussing at some point you never want to give metformin and a contrast medium at the same time because it causes acute kidney injury. This would be an example of that. So the first stage is known as the oliguric phase. Oliguria means decreased urine output, usually less than 400 mLs in a 24-hour period. But that's statistical data, right? It's more important for you guys to understand the concept. The idea is that something happened and the kidneys shut down and you go into the oliguric phase. The kidneys stop producing the urine that it needs to, and all of your values, all of your blood values that indicate kidney function are going up. So we're talking about your BUN, which is supposed to be 10 to 20, it goes up. Your creatinine is supposed to be 0.6 to 1.2. Some books say 0.5 to 1.5. The concept's still the same. It's going to go up. Your creatinine clearance will go down. What that means is the amount of creatinine that your kidneys are excreting in the urine is going to go down. You can't get rid of it, right? That's why your creatinine in your blood goes up. You're going to have something called glomerular filtration rate, which is supposed to be, it's defined as the volume of blood that's passing through your kidneys every minute. It's supposed to be about 100 mLs. Some books say 90 to 120. I've seen 90 to 125, which is the average of blood that's passing through the kidneys every minute. It's not the amount of urine that your body's making. It's the amount of blood that's passing through the kidneys. That lets us know that the kidneys are being well perfused. So if you have that glomerular filtration rate about 100, you're good. But if you have acute kidney injury, what happens to that glomerular filtration rate? It goes down. So your GFR will go down. So this is what's happening. Oh, also your electrolytes. All of your electrolytes are going up. You should know that your potassium, your calcium, your phosphorus, all of the electrolytes your kidneys cannot excrete. But there's a relationship between calcium and phosphorus. You know, we talked about husbands and Sanchos? You guys remember? You remember, right? Okay, good. You remember this part?
We remember.
No?
Yeah.
My point is this. Because all of them are going up, eventually phosphorus causes the calcium to go down. So people with kidney failure also develop osteoporosis because they don't have any available calcium for the bones. You all with me on that?
Yes.
Okay. Now that's all during the oliguric phase. This happens, lasts a few months, right? And during that phase, you have to have dialysis, you have to have all those things to maintain function. Then your kidneys slowly start recovering their function, and you enter what we call the diuretic phase. The diuretic phase is when your kidneys start getting rid of fluids, but they cannot concentrate the urine yet. What that means is they cannot get rid of the waste. So even though the kidneys are producing urine, the patient cannot get rid of the urea, the nitrogen, all that stuff, right? So we still have to continuously monitor those values to see if we require any other type of interventions like dialysis. During the diuretic phase, the patient may develop dehydration, fluid volume deficit, because they're getting rid of all of the fluids and they can't control it. Normally you're supposed to keep some of that fluid for your body, right? In some cases, they can't do that. So that's what's happening during the diuretic phase. That lasts several weeks. And then you have the rehab phase. The rehab phase is when these values go back to normal and your kidneys are now ready to concentrate urine and regulate all of the elements like before the kidney injury. Does that make sense, guys?
Mm-hmm.
That's acute kidney injury. This is also talking about pre-renal azotemia. So when we talk about acute kidney injury, we have to find out what caused it. And the way we describe how it manifests, or the etiological factors, is by looking at the anatomy. So you have the kidneys, you have the aorta and the renal artery, right?
Mm-hmm.
And you also have the ureter that's taking the urine down to the bladder, correct? So I want you to remember this. There's three things that can cause acute kidney injury. Something called pre-renal issues. Pre is before, right? So when you have an issue with, let's say, the anatomical location that's before the kidneys. So we're talking about blood is normally going inside the kidneys, right, folks?
Mm-hmm.
So if you have an issue like you're bleeding out excessively and you don't have enough blood that's going to the kidneys, well, that lack of blood will cause the kidneys to shut down, right? But was the issue inside the kidneys? No. So we call that a pre-renal issue. Pre-renal means something that happens before the anatomical location of the kidneys. You all with me on that?
Mm-hmm.
The second type is something called an intra-renal issue. The intra-renal issue would be like the mixture of your contrast medium and metformin. Those two medications, they go inside your body, they're okay. But once they enter your blood, your kidneys, that's when they cause them to shut down. So that would be an example of an intra-renal issue that's causing acute kidney injury. Does that make sense?
Mm-hmm.
And then lastly, we have post-renal issues. Post-renal issues is anatomically after the kidney. So let's say you have a stone here, a stone there, a stone there, a stone here, a stricture, some anatomical event that prevents emptying and causes backflow of urine. Well, eventually that backflow will cause the kidneys to distend, like with hydronephrosis, and the nephrons will become destroyed, and then you'll develop kidney failure. But that's considered a post-renal issue. Does that make sense, guys? So with this question, it says, which of the following pieces of information should we suggest about pre-renal azotemia, excessive nitrogenous waste? Is it pre-renal azotemia begins prior to the onset of symptoms? Is it interference with renal perfusion causes pre-renal azotemia? Is it pre-renal azotemia is irreversible even in the early stages? Or is it infections and tumors cause pre-renal azotemia?
A.
And B? That's correct. Interference